The teaching project I've created is going to focus on medications given in the cath lab, specifically for patients who are actively having heart attacks, aka STEMIs, and we will review the names, the dosages, and the routes of medications. The goals I've written for this presentation: staff will develop a deeper understanding of why medications are given during cardiac catheterization. Staff will feel comfortable after this presentation speaking with patients about why medications are given during procedures. And I think this part is really important because a lot of times we're who the patients talk to most, because the physicians come in and they're busy doing work, they're placing stents, things like that. So a lot of times the physicians can't take away from what they're doing, and we kind of have to be their right hand saying, hey, this is what I'm giving you, this is why. We'll talk more about it in a minute. And then lastly, staff will understand how to administer different medications by different routes, because some of these medications do have more than one route which they can be given. I've written, after participating in this session, staff will demonstrate how to program an Alaris pump with 2 different medications, including the drip and bolus. After participating in this session, staff will be able to verbalize how anticoagulation impacts patients. Staff will be able to express how dialysis or kidney failure affects medication dosages. And after reviewing medication, staff will be able to correctly identify different routes of medication administration. The medications I've decided to focus on for STEMI patients that we give most often include heparin, Angiomax, Cangrelor, nitroglycerin, and Plavix. Heparin is often given in the case of NSTEMI. Usually NSTEMI patients will go on a heparin drip for a couple of days before they have a cardiac cath done. But for a patient who is actively having a STEMI, it is recommended that they get an IV bolus of 60 to 70 units per kg before the procedure to improve TIMI flow. During the procedure, we will check what we call an activated clotting time. If it's greater than 250, we won't give any more heparin, but if it's less than 250, we will, because if their activated clotting time is less than 250, they are at risk for developing a clot while we are placing a percutaneous intervention or a stent. Contraindications for giving heparin to patients: a known hypersensitivity or allergic reaction, or patients who are known to have heparin-induced thrombocytopenia, and we do have a substitute that we could use for heparin if the patient does have any of these issues. So going back to what I was referring to on the last slide regarding TIMI flow, TIMI 0 is complete occlusion of the coronary artery. TIMI 1 is penetration of obstruction by contrast but no distal perfusion of the artery. TIMI 2, perfusion of entire artery but delayed flow. And TIMI 3 is full perfusion with normal flow. Studies have shown that if the patients receive a heparin bolus of 60 to 70 units per kg in the ER before procedure, that they will have a better TIMI flow before and after placement of PCI. And we've kind of had an issue lately with some physicians saying, oh no, they'll get heparin in the lab, don't worry about it. And other physicians are saying, no, they absolutely do need heparin before, and like they need it in the ER. And like I said, studies have shown that heparin will improve TIMI flow if we give it before procedure instead of right before procedure starts. Angiomax or bilirubin is an IV anticoagulation that we use during placement of PCI or stent. Most physicians that I work with do like to use Angiomax. This is the medication I was referring to that can also be used as a table flush if the patient has a heparin allergy. You can take the 250 milligram vial, mix it in a 1000 ml bag of normal saline, and you can use that as your table flush instead of your heparin saline table flush. For a patient with normal renal function, your bolus is going to be the same no matter if your patient's on dialysis and kidney failure or if their renal function is normal, but your drip will change. So for a normal renal function, your bolus is going to be 0.75 mg per kg and your drip is going to be 1.75 mg per kg. For creatinine clearance less than 30 but not on dialysis, your bolus will remain the same. Your drip will be 1 mg per kg. If your patient is on dialysis, your bolus will again remain the same and your drip will go to 0.25 mg per kg. and contraindications include active major bleeding or any allergic reaction to Angiomax. A really important thing to watch out for your patients who are on Angiomax is bleeding. This happened the other day. There was a patient who may have been over anticoagulated, but nonetheless was on an Angiomax drip and started throwing up blood. Was no longer in the cath lab, was out of procedure at this time. But those are things to watch out for, because then the patient ended up having to have an endoscopy and all the things. They were worried about a GI bleed. Then they ended up being worried about a brain bleed because of other symptoms he was having. So this is a very strong blood thinner, and you really have to monitor your patients when they're receiving this. So cangrelor is used to reduce the risk of stent thrombosis during a STEMI and during coronary revascularization. It is given as a bridge during a PCI. You start with cangrelor and move to Plavix, so it is an IV antiplatelet medication. Your IV bolus is 30 mg per kg, and your drip is 4 mg per kg. Again, this is given IV during stent placement, and usually it'll run for about an hour or two after procedure. That will be up to the physician. And if the patient is NPO or can't tolerate the Plavix, the patient may stay on a cangrelor drip until they are able to tolerate a PO antiplatelet therapy. Nitroglycerin is the only medication we have on here besides heparin, but we don't give subcutaneous heparin for a cath. But this is the only medication we have on here that has so many different routes. Nitro a lot of times is given sublingual before procedure to relieve chest pain. If a patient's coming in by EMS, usually EMS will give nitroglycerin if it's not given in the ER. We can give it IV during procedure or before to relieve chest pain and to also help with blood pressure. But that's the caveat to it, is it will drop your patient's blood pressure, and a lot of people are very sensitive to a nitroglycerin drip. So it's better to start slow and titrate your way up instead of just starting high and then coming down after you bottom your patient's blood pressure out. Physicians will also give it intraarterial at the beginning of the procedure to reduce spasming in the radial artery, because a lot of times the radial artery does not like to be stuck. So we'll give nitroglycerin along with verapamil to help reduce spasming in that artery. And we can also give it intracoronary during procedure to help reduce coronary artery spasms, because if the artery is spasming while we're trying to place a stent, it's not really doing any good. So a lot of times we will give nitroglycerin to help with that during stent placement. Plavix or clopidogrel is one of the most popular antiplatelet medications on the market. The loading dose, like I said, post-PCI is 600 milligrams. It's an antiplatelet used to reduce the risk of instant restenosis. And usually 6 months to a year, more likely a year, patients will be on a dual antiplatelet therapy, and this consists of 81 milligrams of aspirin and 75 milligrams of Plavix. If for some reason the patient is unable to get Plavix or can't tolerate it, they could take things such as FBN or Brilinta, but that will be up to the provider and at their discretion. So I hope everybody was able to take a little something away from this review. This was just a very quick and simple, these are the dosages, and how they affect your patients and how they work. So after this presentation, I want everyone to choose 2 medications to program on the Alaris pump and show that you understand how to work it. And if you don't, we can work through that. And then describe 3 things that could become an issue with administering any of these medications. It could be anything from the patient being NPO or losing IV access. Just tell me how that would affect your patient and how you would find a way to give the medication or what you would do next. And then if you have any questions, please ask. And these are the resources I have for this project, and I hope y'all enjoyed it.